Hello, my name's Kate Chesterman. I'm a GP in South Norfolk, and I also co-host the GPnotebook education study groups. Now in this video, I'm going to be discussing the safe prescribing of corticosteroids. And for this video, I've looked at some really good, nice guidances, one on corticosteroids themselves, but also there's some very useful information on prescribing in the polymyalgia rheumatica and osteoporosis guidances as well. In addition, I found some really helpful information from the Society of Endocrinology and another really good article on a practical guide to the monitoring and management of complications of systemic corticosteroid therapy. So I hope you find this video helpful. So a little bit of background about corticosteroids to start with. So corticosteroids are synthetic analogues of the natural steroid hormones produced by the adrenal cortex. And like the natural hormones, these synthetic corticosteroids have glucocorticoid and mineralocorticoid properties. So those with strongly mineralocorticoid properties affect ion transportation. So they increase sodium and water retention and potassium loss. And they're primarily involved in the regulation of electrolyte and water balance, which is why medications such as fludrocortisone, which have high mineralocorticoid properties, can be useful for conditions such as postural hypotension. Those with stronger glucocorticoid properties, such as dexamethasone and prednisolone, are predominantly involved in carbohydrate, fat, and protein metabolism. So they can reduce the uptake of glucose and increase gluconeogenesis. They reduce protein synthesis and increase protein breakdown, and they cause the redistribution of fat. They can also affect bone strength through a decrease in osteoblast and increase in osteoclast activity, but they also have anti-inflammatory and immunosuppressive properties. And it's because of these anti-inflammatory properties that they play an integral role in the management of many inflammatory and immunological conditions, be these dermatological, ophthalmological, rheumatological, respiratory, hematological, and gastrointestinal disorders. And when we're using them in the management of these inflammatory and immunological conditions, we are using corticosteroids at supraphysiological doses, so doses above those that would be normally produced by the adrenal cortex. In addition, corticosteroids can be used as replacement therapy in adrenal suppression. And in this situation, they are used at physiological doses. So we are just replacing those that we would normally expect to be produced by the adrenal gland. So as I'm sure you're aware, unfortunately, there are a significant number of adverse effects that can be associated with corticosteroid therapy. And we can see this in the mnemonic corticosteroids on the left-hand side of this slide. So they can be associated with serious risks. And we know that these risks and the risks of toxicity appear to be related to both the average dose and the cumulative duration of dose. However, unfortunately, for most glucocorticoid-related adverse events, there is no threshold treatment dose or duration established. We cannot say that the medications will be safe up to this dose or this duration of treatment. It's very variable between different patients. And we do know that they can occur after short durations of treatment and also with frequent short courses. So I'm not going to go through every adverse event that can be associated with corticosteroid use, but I would just like to take a few minutes to think about adrenal insufficiency, which is a really important risk associated with the use of glucocorticoids. So we know that prolonged use of glucocorticoids can lead to negative feedback on the hypothalamic pituitary adrenal axis. And this leads to a reduction in the endogenous production of glucocorticoids. So less glucocorticoids are produced by the adrenal cortex. If we suddenly stop those glucocorticoids that we're prescribing, that can result in adrenal insufficiency because the adrenal gland doesn't have time to recover and to start producing the endogenous glucocorticoids that it should be. And that adrenal insufficiency can last for months or even years. As I've said, duration and dose are not reliable predictors of which patients develop adrenal insufficiency. But we do know there is increased risk with higher doses or longer duration of use. We know there can be increased risk associated with the timing that the steroids are given. So there seems to be an increased risk if steroids are given in the evening or if they're given daily rather than alternate days. And there is also an increased risk with longer acting glucocorticoids. It is worth being aware that inhaled, topical, and intraocular glucocorticoids can also be absorbed to a degree that they cause adrenal insufficiency. So this is not just oral steroid prescribing that we need to be aware of. And so it is worth thinking about adrenal insufficiency if the patient has been taking supraphysiological doses for more than 2 weeks, or if multiple courses totaling more than 3 weeks in the last 6 months have been given, or if the patient has symptoms. Now, one of the problems with adrenal insufficiency is it can present with very non-specific symptoms: abdominal pain, nausea, diarrhea, arthralgia, dizziness, fever, headache, weakness, for example. It's very easy for these non-specific symptoms to be mistaken for symptoms of an intercurrent illness, or even the underlying condition that was being treated with the glucocorticoids. For example, we treat inflammatory bowel disease with glucocorticoids sometimes, and when we withdraw those steroids, if the patient develops abdominal pain and diarrhea, it might be easy to consider that this was a recurrence of their inflammatory bowel disease, rather than maybe considering that this could be adrenal insufficiency causing their symptoms. And this is why it's always worth keeping the possibility of adrenal insufficiency in the back of your mind in any patient who has recently been prescribed steroids. And if we're concerned that adrenal insufficiency might be the cause of the patient's symptoms, then this needs discussion with endocrinology and it needs investigation. In the first instance, this is usually done with an early morning cortisol. But even if this is normal and the patient has symptoms that you think could be due to adrenal insufficiency, then it is worth going on and investigating further, usually with a low-dose ACTH stimulation test. And it is important that we pick up on adrenal insufficiency. It needs treating, and it should be treated with daily physiological replacement doses of glucocorticoids and stress doses. And the reason that it's important to pick up on adrenal insufficiency is because what we really want to do is to avoid adrenal crisis. So as we've said, adrenal insufficiency is difficult to pick up, and it often goes undetected until adrenal crisis is triggered by physiological stress. So this could be infection, trauma, or surgery. And patients who have adrenal insufficiency due to the exogenous steroids they've been taking cannot mount an endogenous cortisol stress response that they need to. And as a result, adrenal crisis can ensue. And this is associated with hypotension, shock, reduced conscious level, lethargy, hypoglycemia, hyponatremia, seizure, and coma. And unfortunately, if not recognised and left untreated, adrenal crisis can be fatal. And so all patients who are known to have adrenal insufficiency and all patients who are at risk of adrenal insufficiency are also at risk of adrenal crisis. And these patients need stress doses of exogenous glucocorticoids at times which would normally provoke a cortisol stress response. So if they develop an infection, if they undergo trauma or surgery. So just moving away a little bit from thinking about adrenal insufficiency to think about some general considerations when prescribing steroids. So first of all, thinking about when we start steroids. So first of all, think about the patient's age. We know that children and older adults are more susceptible to adverse effects. Think about the patient's medical history. Are there any contraindications to prescribing steroids? The main one to be aware of is an uncontrolled systemic infection. But are there also any cautions that we need to be aware of? Does the patient have hepatic impairment, psychiatric disturbance? Do they have any wounds, and would the steroids delay the wound healing? Are there other pre-existing conditions that might be exacerbated by steroid use? For example, heart failure, diabetes, hypertension, glaucoma, myasthenia, renal impairment, thromboembolic disease. Does the patient have systemic sclerosis? When patients with systemic sclerosis are prescribed steroids, there is an increased incidence of a condition called scleroderma renal crisis, when patients get hypertension and a reduced urine output. Is the patient pregnant? Are they breastfeeding? Have a think about the patient's concurrent medication. There are some medications, like antiepileptics, that increase the clearance of prednisolone and make it less effective. Other medications, like some antifungals and macrolides, increase corticosteroid levels and so increase the risk of side effects. Some medications increase the GI bleed risk, such as nonsteroidals and anticoagulants, and others increase the risk of hyperkalemia. And here we're thinking about medications such as bronchodilators, diuretics, or digoxin. Steroids can also oppose the glucose-lowering effect of oral hypoglycemics and can result in significant hyperglycemia. Have a think about the patient's immunisation history. Live vaccines are contraindicated if patients are receiving immunosuppressive doses of corticosteroids, because it could result in generalised life-threatening infections. And really, we should be avoiding live vaccines for 3 months after steroid use. And finally, think about the condition being treated, because this gives us an understanding of the likely dose and duration of treatment needed. And again, this just helps to give us an idea of the potential risks involved. So moving on to think about safe prescribing. As with most medications that we prescribe, we want to be using the lowest effective dose for the shortest possible time. If possible, we want morning dosing, and it might be possible in some situations to think about alternate day dosing, which, as we've said, seems to have a less suppressive nature on that HPA axis than daily dosing. Patients should be given a steroid treatment card, particularly if they're on long-term or recurrent treatment. And now a quick quiz question for you. Would you routinely prescribe a PPI to a patient taking steroids? Well, the answer, interestingly, is no, we wouldn't need to. The risk of peptic ulcer due to steroids alone is low, but it does increase significantly when used with drugs that also increase the risk, such as nonsteroidals or anticoagulants. And so in these patients who are higher risk, we might well consider prescribing a PPI along with the steroid. And also in patients who drink or smoke heavily, have a past medical history of GI bleeding, are of older age, or have serious comorbidity. It's always worth considering the osteoporosis and falls risk. Generally speaking, if we know the patient is going to be taking steroids for more than 3 months, and if they are either over 65 or have had a previous fragility fracture, then we should go ahead and prescribe bisphosphonates. But otherwise, have a low threshold for undertaking a FRAX score and a DEXA scan if necessary, and repeating those risk assessments regularly. And prior to starting, we're encouraged to check a patient's blood pressure, weight and BMI, HbA1c, triglycerides, potassium. They should have an optometrist assessment early in their treatment for potential cataracts and glaucoma, and we should check their height, particularly in children, if children are going to be prescribed long-term steroids. Then, interestingly, This is the suggested monitoring that we should be doing for patients who are on longer term steroids. And I wonder how many of our patients are getting all of this monitoring. This might be a very good quality improvement activity that you could undertake in your practice. So it is suggested that we check a patient's blood pressure at every appointment and their weight and BMI regularly. So not a specific number, but something we should certainly be doing. An HbA1c should be checked 1 month after starting and every 3 months thereafter. And those with confirmed diabetes are likely to need more close monitoring. Patients should be educated about the symptoms of raised blood sugar. Triglycerides and potassium again should be checked 1 month after starting and every 6 to 12 months thereafter. Eye tests should be undertaken every 6 to 12 months, but earlier if the patient develops symptoms of cataracts. And the guidance suggests an early referral for an intraocular pressure assessment if there is a personal or family history of open angle glaucoma, diabetes, high myopia, or connective tissue disease. Height should be checked every 6 months in children, and an early referral if there is any concerns about growth suppression, and annually in adults. And in addition, in adults, in addition to checking their height measurement, it is worth questioning the patient for any incident fragility fractures, so any new onset of back pain. Osteoporosis risk, as we've already alluded to, is important. So review risk and check a FRAX or a Q fracture risk regularly. And we should be asking about adverse effects at every appointment, including symptoms of adrenal suppression. So moving on to thinking about safely withdrawing steroids. So as a general principle, the guidance suggests that short courses, so less than 3 weeks, can be stopped abruptly. But we should be gradually withdrawing if patients have been taking 40 milligrams a day of prednisolone or more for greater than a week. Now, not all patients are obviously going to be taking prednisolone, and this guidance suggests 40 milligrams a day of prednisolone or equivalent. I think it's worth highlighting that within the NICE CKS topic on corticosteroids, there is a very helpful table of equivalent doses. So if your patient is taking something other than prednisolone, I'd recommend having a look at this table of equivalent doses so you can work out how high risk they are. We should also gradually withdraw if the patient has had repeated evening doses, if they've had more than 3 weeks of treatment, if they've had recent repeated courses, a history of previous long-term therapy, or other causes of adrenal suppression, so if they drink heavily or if they're under physiological stress. If physiological stress occurs up to a week after stopping the corticosteroid, then additional corticosteroid cover should be prescribed to prevent that risk of adrenal crisis. And again, there is insufficient evidence to support a particular withdrawal regime. The rate of withdrawal is going to depend on the disease being treated, the duration that they've been treated for, the dose of steroid prescribed, and any withdrawal symptoms. But again, generally speaking, oral corticosteroids can be reduced rapidly down to physiological doses, which is around 7.5 milligrams of prednisolone a day, and reduced more slowly thereafter. And again, within that NICE CKS topic on corticosteroids, there is a table of suggested withdrawal strategies, which gives us, I think, a starting point for making some sensible decisions on an individualised withdrawal regime for our patients. So the final thing I just wanted to highlight is the advice that we should be giving patients when prescribing steroids. So it's very important, as it is with all medications, to discuss possible adverse effects, particularly when thinking about steroids, thinking about symptoms of adrenal insufficiency, and the need to seek medical attention if any symptoms or adverse effects occur. Patients need to be aware of the importance of regular monitoring so they understand why they need to attend for it. They should be advised to take their medication as a single morning dose with food. and to avoid contact with shingles, chickenpox, or measles. Corticosteroids in these conditions are not good bedfellows and can lead to significant illnesses. So unless the patient is known to be immune, they should avoid contact and they should seek urgent medical advice if contact does occur. They should seek advice also if they experience any mood or behavioural changes, and they should be aware that they should not stop their steroids abruptly. It's worth speaking to the patient about lifestyle choices as well, because some of the adverse effects can be mitigated at least to a degree by maintaining a healthy, balanced diet and adequate calcium, normal body weight, by stopping smoking and moderating alcohol intake, and taking regular weight-bearing exercise. Patients should also be advised to carry a steroid card. An example of a steroid card is given on the slide here. And this is just very useful should your patient find themselves in an emergency situation, as it allows any emergency practitioners to be aware that the patient is taking steroids, what they're taking it for, and what dose they're prescribed. And patients should also be made aware of sick day rules. Now, a lot of trusts do have their own guidance, or if a patient is prescribed long-term steroids from secondary care, they're often given specific guidance in what to do with certain illnesses. But if they haven't been given this advice, or if you don't have local guidance, then I think this is a really helpful leaflet from the Society of Endocrinology, which gives us a really good basis and advice for our patients. So it talks about the need for increased doses during sick days, and it gives some examples of what doses should be prescribed. So when patients should need increased medications for minor surgery, more major surgery, for minor illnesses, for COVID. And again, I think this is a really good resource for us and for our patients. And if this doesn't answer your questions, if you're not sure what you should be prescribing, then I'd encourage you again to pick up the phone and speak to secondary care for advice about what patients should be taking to prevent adrenal crisis. And on this final slide, I've just given the references and resources for this video, and I hope you found this helpful.